our own church member, Dr. Sonya Faircloth. She's been at Fifth Baptist for a number of years. She has done one of the main things she did for us during our summer camp was she's a great motivational speaker and a person who can counsel youth. We let her for several years talk to the youth up to 14 years old, the young ladies, and following those presentations, each one of them, the young ladies will come to me and tell me how much more knowledgeable about themselves and how she's opened their eyes. So even in that area of her life, she's blessed. So I'm going to be quiet now and present Dr. Sonya Faircloth.
Thank you, Reverend Brown, for that introduction. Just please let me know if I'm not speaking loud enough. Not only does God want us to have a full lifespan, but also to have a life of abundance in every area of our lives, including physically, spiritually, emotionally, and materialistically. 1 Corinthians 6:19 states, our bodies are temples of the Holy Spirit. So we just really ought to honor God by taking care of our health and taking care of our bodies. Thank you guys for joining us this evening. I'm Dr. Sonya C. Faircloth. I am a board surgically certified podiatrist in the area. I've been in practice in Richmond since 1994. I'm from Portsmouth. A little bit about me, I'm from Portsmouth. This is my second career. And I'm pretty informal when I do talks like this. So please don't hesitate if you have a question to ask it, or I'll try to look at the chats, or if Mr. Henderson will just tell me who's sending me a chat, even though I'll try to get your questions as we're going. Well, lots of times people think about podiatry as, oh, just a foot. Well, that's not really so. Would you want somebody treating your infection or doing surgery or something on you that don't know anything else about the body? We do. We treat a little bit of everything, from very super simple things such as an ingrown toenail, right up through to surgical reconstruction, whether that includes amputating things or correcting deformities or correcting fractures, infections, that sort of thing. So I'm just going to start off with from simple to more complicated things we may see, or more serious things we may see. Of course, one of the first things that people think about when you think of podiatry is diabetic foot care. Well, I kind of think about just foot care, because what goes for the diabetic really should be for anyone. A lot of people don't realize that not just with diabetes, but as you get older, or you may have back issues, you will start getting some numbness, or you may get neuropathic symptoms, which typically include numbness. Some people say a searing, unrelenting pain going down their leg or in their feet, burning, stinging. It can come from a whole host of reasons. But the more important thing is that you may not feel sharpness. You can feel someone touch you, but you could step on something sharp, or you could have an injury, or you could have a wound. And as humans, we don't take it serious because it doesn't hurt. Well, you really need to start looking at your feet, particularly if you do have neuropathic symptoms or if you're diabetic, because you could have some issues going on and you won't know it if you don't visualize it. Don't get excited by a lot of the crazy commercials that are on TV today with those neuropathic centers. They are out to make money. I'm not in the business of bad-mouthing anyone, but most of those neuropathic centers are ran by chiropractors, and I have found no science that supports the things they say that they can do for neuropathy. And anyone that I've ever known to go to those clinics have not gotten any relief. If you think real hard about it, if we could cure nerve damage, we wouldn't have any paralyzed people. So sincerely, we are at this point in evolution, is that we can calm down neuropathic symptoms. You're not going to totally get rid of them. By neuropathic symptoms, I mean burning, searing, sharp, stabby pains. Lots of this come from people who may be diabetic or people who may have had a back injury. The smallest nerve at the end of your foot starts growing from your back. You may also see it on people who may have alcoholism, can cause neuropathic symptoms. MS can cause neuropathic symptoms. Another biggie is I get a lot of people who tell me, I don't know why my legs sting and burn, and I get sharp, stabby pains. And as you talk to them, you find out that they've been undergoing chemotherapy treatments. Chemotherapy can also cause neuropathy. So the biggest thing is that you know what the symptoms are, so that you know, I need to start looking at my feet. First thing people want to say is that my belly's too big, or I'm older, I can't bend over to see it anymore. I always tell people, go to the dollar store or Family Dollar, get a big mirror, put it on the floor. You can look at the bottoms of your feet that way. But that's one of the biggest things you need to be concerned about if you have neuropathic symptoms, no matter what the etiology is, whether it's from diabetes or some other type of illness. Some people have neuropathy for no reason. Some of the things we do for neuropathy, particularly if it's from diabetic issues, is controlling your blood sugar will make it a lot better. Some people, we will give them vitamin therapy like vitamin B complex daily, or alpha lipoic acid, which is something you can get from a vitamin store, 600 milligrams a day. If those things don't work, those are the people that now we will give something, a prescription medicine like gabapentin or Lyrica. Both of them work pretty well, calming down your symptoms. But I tell people, if it's just an awareness, I know it's numb, Dr. Faircloth, but it doesn't keep me awake. It really doesn't hurt. I don't see the need in you taking a medicine, one more pill, just because you have numbness. It's just numbness. If it's pain, now we're talking a different story. So let's get back to the simple stuff. Ingrown toenails. People want to think, oh, it's the way I cut my nail, or I wore my shoes too tight. 99% not so. Typically, if you have ingrown toenails, it's because mom, dad, someone else had ingrown toenails. They are typically the pattern of your nail. It is the way your nail now wants to grow, curved in. Sometimes you can just round the borders, but a true ingrown nail, the only real way to get rid of it is that we numb your toe, we remove the sides, put a medicine behind them, so that now we created a straight border. Typically, if you get that done, you won't have any other problems. Very, very seldom, unless it's a very thick, deformed toenail, do we have to remove the entire nail. More of the simple. Everybody wants to know, oh, I got a thick toenail, I think I have fungus. Not always. Sometimes thick toenails, that can be an inherited thing. Mom, dad, if they got thick nails, you may have thick nails. If something very heavy fell on your foot, or if you worked a long time in steel toe boots, or an athlete and you're constantly creating a turf toe, that is damaging your nail where it grows, and it will probably always be thick. With that person, you keep it filed back. If it's painful, you remove the toenail. Of course, if you truly have fungus, one of the best ways is by taking an oral medication specifically designed to treat fungus. That truly is the most superior way of treating a toenail if it is truly a fungus. Dry skin. You don't have to spend money on all these hocus pocus lotions. Go get something like good old dollar store Vaseline, or one of the better medicine lotions for really dry skin is the Gold Bond diabetic lotion, whether you're diabetic or not. Just because you have dry skin, if it doesn't really itch, then it's not athlete's foot. It's just dry skin. So let's move on to a few of the other issues. I'm trying to keep my eyes to see if anybody has sent any questions. I don't see any, but help me out, Mr. Henderson, if you see any questions that pop through, because I'm just maybe doing it wrong. Please let me know. Excuse me?
We're monitoring.
I'm sorry, say that again.
We're monitoring the chat.
Great, thank you. So we just talked a little bit about diabetic foot care. The biggest thing with diabetic foot care is that you keep your eyes on your feet. If something doesn't look good, I would much rather you come in and I say, well, I'm sure any doctor would be pleased to tell you, you know what, it's nothing to worry about. Then for you to come in and it's way far gone. I cannot tell you how many people I have had to come to see me, and by now they have a gangrenous wound or a gangrenous toe. I've even had someone, I've taken the sock off and the gangrenous toe came off in the sock. That is someone who should have seen that, or their family members should have seen that, and they should have come in before. I would much rather see you to prevent a problem or at the beginning of a problem until we're at the end of the problem. Once again, with diabetes, well, this pertains to a diabetic or someone that may be 55 plus. Pain in their legs, in their calves, in their feet. Wow, after I walk to the mailbox every day, when I get to the end of that driveway, the back of my legs and my thighs just really hurt. Typically, that may be a symptom of peripheral arterial disease. A lot of people think that people who lose limbs are diabetic. I see just as many people that aren't diabetic losing a limb, secondary to peripheral arterial disease, meaning your arteries no longer work as they used to. It's what people used to call calcified or clogged arteries. If I suggest to anybody, if you have a family member, particularly an immediate family member that has had an amputation or that has known peripheral arterial disease, you need to keep a watch on yourself. If you start getting calf pain, leg pain that just won't go away, it's exacerbated as you walk, but it goes away when you stop, you need to have a vascular exam. This day and age, it is so easy to hone in on arterial disease early. And most of the time you can have what's called an angiogram, 15-minute procedure. They make a half-inch cut in your groin, blow air through it, blowing plaque through your arteries, restoring blood flow. Then there are some people, they may be a little bit more advanced, and they may have to get a bypass. A bypass is when you have, let's say you have a clogged artery in the middle of your leg. So you take the artery, you clip it off at the knee, you attach another piece of artery or vein to it, bypass that clot and reattach it mid-leg. Once again, restoring blood flow to your lower limbs. Both of those are very common procedures now. Bypasses are not needed as much as they used to be now that we are more cautious in diagnosing this issue early, and angiograms and angioplasties work very, very well to restore arterial circulation. You may hear me or your doctor refer to that as revascularization of your lower limbs. That means restoring blood flow to your lower limbs. That is what caused most people to lose limbs. Swelling. You're gonna get a certain amount of swelling by the time you're 55 to 60. I tell people, go to church, look at everybody's legs, particularly ladies over 60. They're gonna look puffy. If you have swelling that is not there in the morning, but it's not there in the morning, but it increases as the day goes on, you may just have some, what we call venous insufficiency. Your veins just don't work like they used to. It's not necessarily anything is wrong. Some people, if you have heart problems or kidney disease, you're going to retain fluid in your legs. Definitely, if you have some swelling and you notice shortness of breath, that is something you need to see your PCP. Or if I just really can't breathe, you need to go to an emergency room. Swelling with shortness of breath can indicate that you're having what we call a DVT, or layman's terms, a blood clot in your legs. By the time you get the shortness of breath, that means that clot has broken off and is in your lungs. Both of those situations can be life-threatening. But standalone swelling that is not there in the morning, but increases as the day goes on, that is typically because you're retaining fluid. It can be from something as simple as incompetent veins, meaning they just let the fluid regurgitate and don't push the fluid back up. Or it can be because you may have the beginnings of congestive heart failure. Some blood pressure medicines can cause you to retain fluid. Having high blood pressure itself can cause you to retain fluid in your legs and ankles. People who may have kidney disease or the beginning of kidney disease will start retaining fluid in their lower legs. So I would recommend you get it checked out by your podiatrist or your primary care doctor if you're just having swelling. But if you're having swelling and you have shortness of breath, pain in your calf muscle, pain in your thigh, that can be an emergent situation. And you should probably go to the emergency room to make sure you don't have a blood clot or what we call a pulmonary embolism. Pulmonary embolism is once the clot has broken off and it has traveled to your heart. Once again, that's an emergent situation. One other thing about diabetes is something called Charcot. Charcot can happen and it can stand alone, but you mostly see it in diabetics or anyone that may have neuropathy. Charcot is when your foot, one foot may start contorting. It's not in the same shape that it used to be. It may be bowed outward. It may be like this. Instead of your foot being flat or having an arch, it's like a rocking chair. We call that a rocker bottom foot. Most of the time, people will come in and say, my foot's been swollen for a long time and I just can't get the swelling down. And it just doesn't look right. It doesn't look like the other foot. It's fatter, it's deformed. That is called Charcot. When you have neuropathy, which is nerve damage, nerves tell our muscles, our bones, everything what to do, even our skin. So when you start getting neuropathy, you may get some discoloration. You may get very dry skin, very dry nails, but your muscles don't know what to do. And typically that person with Charcot, their foot will start just collapsing. Instead of it being like this, your foot would be like a rocking chair. That's where your midfoot or your ankle will start collapsing. If you take an x-ray, it'll look like somebody took a hammer and beat up the foot and you have lots of broken bones. Inexperienced person reading an x-ray or reading an MRI will think that it's multiple fractures, or they may think that person has bone infection, which we'll talk about in a second. That's called osteomyelitis. And it's very easy to get the two mixed up, but that's where it comes from getting a history from the person. And if you look at enough x-rays, enough MRIs, just for that specific thing, then you can tell the difference between what's called Charcot versus bone infection. Typically with Charcot, if the foot is just deformed, we get you in a custom shoe to support what you have. When the Charcot is active, it may be red and warm, may hurt, may mimic gout, which we'll talk about next. And we'll put you in a cast until that flare up goes down. And what we do is we just maintain your shape. If your Charcot gets way expanded and out of control, there are some people, their ankles will be bowed out so much that the ankle bone may actually start coming through the skin. That is the person we do what's called a Charcot reconstruction. Very involved, very long procedure. Years ago, and even now sometimes, some doctors, especially orthopedics, would say, you just need to amputate the foot. Well, not necessarily, because we do know how to reconstruct that kind of foot now. Sure, your basketball career will be over, But what we are doing is giving you a platform to at least stand on instead of losing a limb. A lot of people will get a wound in the middle of their foot under that rocker bottom foot. And that is because that's an apex of where the bone is sticking down like this. Typically with that person, if the Charcot is in an inactive phase, we can just go through and just trim back that excessive point of bone that's sticking out, making it a flat surface, put them in a custom shoe, person is fine. Not everyone has to go through or need to go through the full reconstruction. Let's get to gout. Gout can be seen in anybody. I've seen gout on kids as young as 16 up through 100. Gout can be inherited. Well, let me back up a little bit. Gout comes from someone either overproducing what's called uric acid or under excreting, meaning their kidneys are not releasing enough of it. Doesn't mean you have kidney disease, just means your kidneys don't release enough of uric acid. So you either overproduce or you under excrete it. With both of those cases, that uric acid will lodge in joints anywhere. A lot of people think big toe. Yeah, it can go to the big toe, but it can go anywhere. I've seen it in ears, nose, ankles, feet, any place you have a joint, you can have the potential to get gout. Once again, it can be inherited. You have a greater chance or predisposition of getting gout if you take blood pressure medicines, especially multiple blood pressure medicines. Sometimes we'll change your blood pressure medicine, or we just treat you with medication specific for gout that you just take daily, like a vitamin. Then you have the unfortunate people where the gout will just lodge in their joints, and it can either, sometimes it's very painful, sometimes it's not, but you will get nodules, golf ball size, in the middle of your foot, on the side of your foot, in your big toe. If you were to cut that open, you would see a substance that looks like cottage cheese. That's called gouty tophi. It's where from over the years, gout has accumulated in that joint. That's an easy one. You just cut it out. Not everyone with gout gets gouty tophi though. Most people with gout, you're just gonna wake up one day without having any injury. That area is gonna be red, hot, and swollen. Those are the three things with gout. It gets very warm, gets very red. Next to a kidney stone is the most painful thing you probably ever feel. You can't even put a sheet across it. You can't even put your sock on, it hurts so bad. Typically, that is gout. Very, very seldom is it going to go away by itself. I have had some people who waited and sit there 3 weeks in severe pain, and they said, oh, it finally went away, but I couldn't walk for 3 weeks. Well, there are a lot of things we can do and not let you be in discomfort like that. Typically, we'll give you some oral prednisone. If you're really bad, we'll start off with a cortisone shot, but then there are other oral medications you can take specific for gout. Some people are on a maintenance medicine. If their uric acid level is extremely high, then they take a maintenance medicine daily so that they won't have a reoccurrence of it. But gout is a type of arthropathy. Regardless of what you read or see, it is very, very, very seldom to foods. You'll hear people say, I don't know why I have gout. I stopped eating seafood. I stopped eating meat. I stopped eating that, but I still have gout. That's because it's in your chemical makeup. It has nothing to do with food. Very, 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 very seldom. I have never seen it associated with what someone ingests. And if it was food, why did it wait until you're 50 years old to get it? If you've been eating shrimp since you were 5 years old, then you would have gotten it back then too. So don't be so quick to blame it on food, because typically it is not. But thing about it is, you don't have to suffer with it. There are easier ways to get it under control. Some of it, like I said, may have to be surgically, but that's not very often either. I had mentioned something called osteomyelitis. Osteomyelitis is a fancy schmancy term for bone infection. You don't have to be diabetic to get it. Anyone with a long-standing infected wound can get osteomyelitis. From here, I will keep referring to it as bone infection. I'm one of those doctors, I don't like to use a lot of fancy terms because I'm not trying to show you how smart I am. I want you to understand what's going on with your body. So I try to talk in layman's terms so that you will know actually what's happening to your body instead of trying to remember some term that I used. But if you have an open wound for a long period of time, you're getting germs in it. You're getting bacteria in it. Especially on the feet, there is not a lot of fat between your skin and your bone. If you have a long-standing wound on your butt, it may take a long time for it to get to the bone. You have a lot of fat in between bone and skin, but in your feet, there's not that much fat. So rule of thumb is if someone has had an open wound for 30 plus days, not always, but 80% of the time, that bone is going to end up being infected. And that's the importance of taking care of an open wound, particularly if it's deep. Because once the bone gets infected, it is not as easy as taking an antibiotic. Bones don't have the capillaries going to them like your skin does. So typically, if it's bone infection, we either have to cut off that piece of bone or scrape away that piece of bone, put you on maybe IV antibiotics. The easy way I tend to explain that to people is when you have a dead leaf on a plant, that leaf is not going to come back to life. You need to get rid of the dead leaf and then the rest of the plant will flourish. But as long as you have that dead leaf up there, it's not going to flourish. And it's not an easy conversation to tell people, we got to remove the tip of your toe, or we got to remove your toe, or we have to remove the front part of your foot. Some people are below the knee amputation. That's not an easy conversation. However, it is much easier and nicer to deal with losing a portion of a toe than to lose a portion of the foot. Or if I have to lose the bottom of my leg, that's much nicer than losing my life. Because if you don't get rid of the bone infection, it's going to spread. Just like having a piece of mold on a piece of cheese. If you cut that piece of mold off that cheese, the rest of that cheese is good forever. But if you don't, in another day or two, you will see where the mold is growing and increasing and invading the cheese. That's what happens if you keep something infected on your body without removing it. Whether it's gangrenous tissue, whether it's an infected bone, you want to stop the process. None of us are interested in having you to lose any limbs or anything like that. However, sometimes it's a choice you have to make to save a life so that the person won't get septic. Being septic means you have an increasing, growing infection, which is life-threatening. I'm sure we've all been there before where maybe you had a hangnail and you just pulled it off. It was a little red. Well, the next day or the next 2 days, it was more tender and more red. That's a spreading superficial infection. But let's magnify that by 10. That's what sepsis is like. When you have a raging infection and it just continues to grow, you have to treat it. You have to get rid of where the infection is at its worst. You don't always have to amputate something, but once it gets to the bone, you do have to either remove bone or scrape the bone. And that's what we absolutely want to avoid. But if it gets to that point, we want to take care of that as soon as possible so that we can lose the least amount of tissue as possible. And sometimes now, even with that, we use, there are so many artificial skin substitutes we use now to close wounds. Let's get on to injuries and pain. Before I move on, are there any questions about anything yet? I don't see any, and let's
I don't
see.
see any
My good
comments.
person. Okay, great. One of the most common things that we see on anybody, right from a child through an adult, is arch and heel pain. People automatically assume when they have arch or heel pain that they have a bone spur. Not always so. And even if a spur is involved, we don't always have to do anything surgically with the spur. Typically, when you have arch and heel pain, it's something we call plantar fasciitis. It is a lack of support. It is an overuse injury. Just about anyone can get it, but you do see it more on people who may be athletic or who do a lot of standing, a lot of running, that sort of thing. You can see it on a high arched person just as easy as you can on a low arched person. You can see it in children simply because their heel bone, instead of being in one piece, is still in two pieces. So you have tissue pulling those two pieces apart until that heel bone becomes one solid bone. Typically, when you have arch and heel pain, if it's oh my God pain, we may start off with a cortisone shot. But if it's not that terrible, then we typically start off with steroids by mouth for a week, give you some stretches or physical therapy, and put you in something that you can wear in your shoe to support your arch. I would say about good 60% respond to that and they are very happy. Well, then you have another few, they're not responding. That's the person I'm going to give a cortisone shot to, but you still have to stretch it. You still need to support your arch. Fine. Well, out of those, you may have another 5, not quite 10%, but maybe 5 to 10%. They're responding to nothing. That is the person I do something surgically to. If there's a heel spur, I'll remove the heel spur, but you also need to release the plantar fascia. The plantar fascia, if you strum the bottom of your foot, you'll feel a thick cord-like structure. That is your plantar fascia. If it is very tight, that's when you can start getting arch and heel pain. When you're in the bed, no problems. You're sitting down, no problems. Most people say, wow, after I've been laying in the bed and I get up, or I've been sitting or driving, that first step just about throws me on the floor. That is typical plantar fasciitis pain. If that cord is super tight and those other remedies don't work for you, then that's the person that I surgically release the plantar fascia. If there's a heel spur involved, I remove that as well. Now that would be pain on the bottom of your heel. Now on the back of your heel, a lot of people get pain back there secondary to Achilles tendonitis, meaning that big thick muscle back there that becomes your calf muscle is too tight. You may palpate or feel back there and feel a lump. Most people may have a bony spur back there. Don't always need to do anything with it though. Same thing that we did with plantar fasciitis. Some physical therapy to stretch it out, some type of anti-inflammatory, whether it's by mouth or by injection. Put a heel lift. I would say a good 80% of your people walk away, never come back, they're fine. You are going to get another 10 to 15% that I will end up going in, removing their Achilles tendon, resecting the bony spur, and reattaching the Achilles tendon. Some people do need that, but just because there's a spur back there doesn't always mean that it has to be addressed surgically. A lot of things can be addressed non-surgically. Lots of people will come in and say, wow, the top part of my foot looks like an egg shape and it hurts really bad. Most of those people, I can relate it right back to an injury. Some people may not even know they had an injury. You take an x-ray and lo and behold, they have a fracture in the long bones in the middle of their foot. I can't tell you how many people I have that don't even know, they don't know why their foot is hurting. They didn't even realize they had injured themselves. But when you have that oval shaped swelling on the top of your foot and it really hurts, you need to get it checked out and x-rayed because 9 times out of 10 it's a fracture. With a fracture, if it is displaced, meaning a stress fracture or non-displaced fracture is going to be, the ends will line up like this. If it's a displaced fracture, it's going to be like that or like that. The two ends are not going to be a joint. That is the person that I do something surgically to realign the broken edges of the bone. We do that by either wires, screws. Of course, when we do these surgeries, you're asleep. There really is very little pain afterwards, as long as you do the things your doctor tells you to do, whether it's on crutches, whether it's in a guarded shoe. But not all fractures have to be addressed surgically either. Another common thing we see is a neuroma. People will tell me, particularly women, we tend to wear shoes that are not as thick on the bottom, but they'll say, wow, it feels like a hot poker sticking up in my foot when I step down, in the ball of my foot. And if you go through each web, you'll find one or two web spaces that are really, really tender. That is a neuroma. A neuroma is an enlargement of a nerve that's, yes, I see your question about the tendonitis. As soon as I finish talking about the neuroma, we'll talk about that. A neuroma is an enlarged nerve that's going to be right in between the two knuckles in your foot. Typically, once again, we can shrink it with cortisone, put you in what's called an orthotic, and most people are fine. Mine was really bad. I thought I was going to have to take it out, but I just injected it a couple of times, start wearing a custom insert. I've been fine for 10, 15 years. Some neuromas, if they don't respond to therapy and they're still hurting, that's the person. Of course, I'm using my hand, but we're speaking of your foot. Take you to the OR, make a cut here, find that nerve, resect the nerve. Some people with neuromas, that can happen too. When you say, I got a question that asks, can you have tendonitis on the top of your foot? You can, but it depends on where it is. Typically, you won't have tendonitis on the top of your foot. Typically, tendonitis, you may have it on the side of your foot. If it's going to be on the top, it might be where joint space is. More than anything, pain on the top of your foot, more than likely is coming from a general term we use called capsulitis, meaning inflammation in between the joints in the middle of your foot. Sometimes there's some arthritis forming in the middle, in the interspaces of the joints in your midfoot. The young lady that had the question about tendonitis on the top of your foot, can you describe where on the top of your foot it is? And once I see that question, with you describing where it is, I'll come back to your question and I can further answer that for you.
It's sort of on the
As
middle
you
part
age,
of the. It's sort of on the middle part of the
middle
foot.
part of the foot.
It's like a swelling.
Okay, I promise you that you don't have tendonitis. I will promise you, you probably have, you may have a cyst with some arthritis under it, meaning a bony protrusion. So is it like maybe around in here on your foot when you say the top?
Yes.
Okay.
Yes.
I think you have some arthritis that has formed the bony spur. It looks like swelling, but it's really arthritic bone pushing up. Sometimes it'll feel a little fluctuant, and that would mean that you formed a cyst over it, trying to protect the area. Typically with something like that, we may inject it. If oral cortisone doesn't work, we'll inject it. And I tell people, don't lace your shoe up that tight right over that spot. Half of the people are going to be very happy. The other half, I may need to go in and remove the cyst and shave down the bony spur that's sticking up. But I would beg to think that you don't have tendonitis on top. You probably have an arthritic process, whether it has formed a bony spur or not. Does that help any? Does
It was a
that help answer your
podiatrist that told me it
question?
was tendonitis, believe it or not.
Well,
Uh,
you got to
Thank
remember,
you.
everybody has their own thing and their own way of doing things. And that's just like, you can go to one restaurant, he may cook his steak different than that other one cooked their steak. So I
But touching it, it
really
sounds
don't think
like
you
it's
have
more like
tendonitis.
what you said. When touching it sounds more like what you
If
said.
it's
It feels more like a bony.
sounds like you have a bony prominence right there, because you're
Thank you.
not typically going to have tendonitis right there. And the tendon right here, you got to remember, it starts up here and it goes all the way down. So if it was tendonitis, it should be hurting all the way through, not just right here. But if you can press it and it feels hard, you probably have a bony spur right there. Did they try injecting or giving you anything, any Motrin, any steroids or anything like that?
He didn't do anything.
Did they take x-rays?
No.
Once again, that's just in my perspective, I don't think that person did enough investigating to accurately diagnose you. I had another question. I'm going to try to see if I can pull it up. Mr. Henderson, help me out. There was a second question there.
It
Says,
Uh,
as you age, does your foot become less flexible? As you age, does your foot become less flexible?
Absolutely. I don't know about you, but nothing on my body is as flexible as it was when I was 16, including my feet. Yes, your feet may become less flexible, no doubt about it. I get people all the time telling me I can't wiggle my toes like I used to. Nobody can. You know, just because you can't wiggle your toes, fine. If it doesn't hurt, I would say don't worry about it. Your foot is just like the rest of your body. Unless there's anything else, I'm going to move on to some of the, once again, more common things. Bunions and hammer toes. Bunions are not exclusive to women. They do not come from your shoes. Nobody in their right mind would wear a shoe that tight. I will guarantee you, if you have a bunion, whether you're male or female, mom, dad, grandma, someone else had a bunion. It's an inherited weakness in your bone structure. That's just like if you have big ears, mom or dad had big ears. It's not because you wore your hat with your ear sticking out. Bunions are typically an inherited weakness in your bone structure. Yes, wearing a snug shoe can aggravate it. If it's a small bunion, I tell people, wear a wider shoe. Watch your sneakers or your shoes. Don't wear a shoe that has a seam that cuts across it. If those things don't work out, the next step is, yes, I can surgically correct it, but let's talk about, you may say, I don't want surgery. I'm never. So what can you do? Wear a wider shoe. Hang on just 1 second. Let me grab one thing for you. I happened to be in my study where my treadmill is, and I saw these shoes sitting on the floor. See how these shoes are mesh? I don't have any seams on this shoe. If I put my hand in it, you can see me moving my fingers and everything. Most people, particularly my older people, and they may be too much of a risk for surgery, or they don't have the time to take off from work. What else can I do, Dr. Faircloth? Wear a shoe, like I just showed you, that is soft topped. There are no seams cutting across the top of your toes. There, where you would have a hammer toe, there's no seam cutting across your bunion. Wearing a wider shoe, taking a leave if it bothers you. There are some much older people who definitely are not candidates for surgery. That's the person I tell them to get a sandal. Just about any store, I don't care if it's Walmart, you can find those sandals that are, I don't have one in my room, that are, they're like Teva sandals, but they have a thick sole on them. They have a strap across here, and they're cut out here and here. Those shoes work beautifully for people who may have bunions or hammer toes, especially if they're older and they're too much of a risk for surgery. Okay, wear socks with them, it's the winter time, but that's really all you can do if you have bunion pain. Anti-inflammatories, alter your shoe gear. If those things don't work, the next step is that we do something surgically. So let me make sure that everybody is on board with what a hammer toe and a bunion is. A hammer toe is when your toe is like this. It can be any toe, but it's typically your second toe, or you have that callus on your fifth toe. A lot of doctors don't go to the extent to explain to people calluses come from underlying bony prominences. So the worst thing you can do is to get those corn pads. They have acid in them. They're eating acid through your skin. If you think about it, doesn't sound quite right that I should be putting acid on my skin. I get people all the time to come in and say, well, I use those things and now it hurts like crazy and it's still there. That's because the acid has ruined your skin. But not only that, it's a bony deformity. Acid's not going to eat away the callus. I mean, it's not going to eat away the callus. It's certainly not going to eat away the bone. So once again, come in and keep the callus trimmed back on a regular basis. Most people average every 3 to 4 months. Some people that doesn't work well enough for, that's the person I talk to about surgery. So hammer toe surgery, you make an incision here, you take out a sliver of bone right here, so the toe lay straight. Most people always get that nasty callus here on the side of their fifth toe. Same procedure. Wider shoe, or we do something to correct the bony deformity. A bunion is when you have your big toe, it's going over a little bit and you have that knot sticking out. That is bone. I get people all the time saying, well, I don't know why you're saying that, Dr. Faircloth. I never used to have that. Once again, I don't want to admit it, but it's a whole lot of things on my body I have now that I didn't have when I was 16. Your body changes. People don't equate that your feet are your body as well. Your feet change, your teeth change. You get high blood pressure. Your body changes as you get older. Your feet can change as well. You may have had a little bunion, or you may not have had one when you were 16. Well, life has progressed and you have one now. So it's not anything you did. It's probably nothing you could have done to avoid it other than change your parents, but you can certainly alter your shoe gear. If that doesn't work well enough, then we can do something surgically. A lot of people will get to where I can't bend my big toe and it hurts. Once again, that toe may have had some kind of trauma, could have been 10 plus years ago. And now I see your question about the orthotics. I'll answer that in 1 second. Lots of people will develop arthritis in that toe, particularly a bowler or a golfer, because that's the toe you pivot off of. If you stub that toe or something heavy fell on that big toe, you can develop arthritis here. And now that toe just won't move and it hurts. If cortisone injection doesn't help well enough, next step is that we do something surgically to address the arthritic process in your toe. Mr. Henderson, help me out with this one. I only saw the beginning of her question. It said, I have 2 pairs of orthotics. What did the end of that sentence say?
It's a long.
It's a male.
Okay.
Hold on a second.
Okay. It says I have. Okay. I found.
You see it?
I'm sorry, you guys. I got it. Mr.
Okay.
Henderson, I got it. I finally figured out how to pull up my chats without interrupting. I have 2 sets of orthotics at this time. They serve the purpose. I stopped wearing them. Too worrisome. 2 years ago, I had pain in my knees, blah, blah, blah. Well, I would tell someone that if you wear orthotics, I would not ever stop wearing them. It depends on why you were wearing them. That's just like if you wear glasses. It's not like I can wear them for 6 months and now say my eyes are corrected, I don't need them anymore. Typically, I personally don't like good foot store. they will charge you $200 to $300 for something that really only costs 20 or 40. Like in our office, we use two types, custom made ones and a generic one. I hardly ever use custom ones anymore. I use my $40 generic ones, work just as well. And you got to remember, everybody's out trying to sell a product. So when you say, why should a customer come to you before investing in a good foot store system? Well, that's your preference. But I will tell you, more than half of my patients who go to Good Foot, they end up coming right back because they end up getting a product that was way too expensive and it only worked for like a month, or it really didn't address the issue. And typically, if you were having pain in your knees, you were having another issue. And your orthopedic should have gotten to the bottom of that issue. But I would say that the cortisone with the insoles, probably what made the difference. I highly doubt if the insoles you got are the sole reason that there's a difference. And typically the Good Foot store, they will tell you they are custom made, but typically they take a product off of the shelf and they heat mold it. That's not what a custom made insert is. Any other questions, or who asked me that question? Did I answer your question, or is there anything else you have about what was going on with your knees?
Thank you, doctor. You answered. I do have a follow-up question. What is the purpose? You said investing in a Dollar Tree mural and plant your feet on it. What's the purpose behind that?
Well, to put on the floor so you can look at the bottoms of your feet. When I tell people they need to start inspecting the bottoms of their feet, the number one question I get, oh, my belly's too big, I'm too old, I can't get my foot up that high anymore. Get a big mirror and put it on the floor. Hold your foot over it. You can look at your foot. You're looking to see, do I have any bruises? Do I have any wounds? Do I have any sores? I have people that have sores and the bone is sticking out. Literally the bone is sticking out, but they have nerve damage. They didn't know they had a wound. They only came to the doctors because whoever was doing their laundry asked them, why do I keep seeing blood in your socks? But that's why you're looking at your foot, particularly if you are diabetic and if you have known nerve damage, so that we can catch a problem at the inception and not in the middle or at the end of the situation. Does that help?
Yes, ma'am.
Did that answer?
Yes, ma'am. Thank you.
Sure. Sure.
Doctor, are bunions more prevalent in flat feet?
No, you can see them on absolutely anybody. You know, people want to blame everything on flat feet. Before Vietnam, they would not let you join the military, thinking flat feet were not good. I feel that flat feet are a normal anomaly. Take a group of 30 people, I guarantee you at least 20 of them are flat. Notice flat feet don't keep you out of the military anymore, because in the 60s, during Vietnam, they realized that is the best type of platform to march on. People who have flat feet have just as many problems as people who have high arched. Mostly high arched people typically have more problems than people with flat feet. Now, there is a particular type of flat foot, meaning something we call hypermobile joints, that can predispose you to getting a bunion quicker. But to say that you only see bunions on flat feet, absolutely not. You can see them on just about anyone. Just like I'll get people to come in, well, I have a flat foot. Does anything hurt? Well, or little Johnny has flat feet. Okay, does it hurt? Well, don't worry about it. But his feet are flat. Is he hurting? Ask little Johnny, does this inhibit you from running, jumping, doing anything? He says no. I tell parents, just get an arch support and put in a shoe, he'll be fine. You don't always have to address a flat foot. Now, flat foot with pain, just like a high arch foot with pain, yes, that's something we need to investigate and address. But just because you have flat feet, that is not typically a problem. Is there a surgical procedure we can do to produce an arch? Sure. On kids who may have a flat foot that is hurting, we put an implant in the middle of their foot to raise their arch. On some people who are super flat, particularly teenagers or adults, and they really hurt, I mean, nothing stops them. It is not a plantar fascial pain or anything like that. That is the person we may fuse the midfoot. Well, let me tell you, if I fuse a 18-year-old midfoot or 16-year-old midfoot, his basketball career is done. Most people will end up getting some type of arthritic annoyance if they have a midfoot fusion. So, you know, just because you see something that doesn't look right, that doesn't necessarily mean it is a problem, just because it doesn't look like everyone else's. I tell people, let's address what is causing your problem. This is an outrageous or an over-the-top example, but that's just like saying, my skin doesn't look like his. Does that mean it's something wrong with me because my skin is darker? Absolutely not. It's just a normal anomaly. If it's not bothering you, it's not causing any problems, you don't really need to do anything with it. A lot of people will get a callus like here or here on the bottom of their foot. Primary care doctor will tell them it's a wart. If it's right under the knuckle, promise you it's not a wart. Typically, that is because the long bone right here associated with that callus is out of line. So when you hit the ground, that's where all the pressure is going. And just because of friction, you get that painful callus. Once again, just like everything else, we trim it back on a regular basis. Now, this is where orthotics really do work wonderfully, because they uplift and splay and put all of your metatarsal hits on an even plane. Most people do very well with that. If they don't, then I do something surgically to realign the bones. When you have a wart is not going to be right under a metatarsal hit. It's going to be just about anywhere. Good way to distinguish the difference between a wart and a callus. Warts will hurt when you squeeze them. And if you look close, they have little black dots in them, very fine black dots. Warts are extremely vascular, and the little black dots are capillary endings. If you shave back a callus, it's not going to bleed. If you shave back a wart, you're going to get some pinpoint bleeding. Typically with warts, very seldom do they spontaneously disappear. Warts above your waist are called exophytic, so they grow out of the skin. Those are the ones that are real easy to treat. They may spontaneously disappear, but the warts that grow below your waist are caused by a different variant of the wart virus. They're called endophytic, so they grow inside instead of outside. So what you see is deeper on the outside. Typically with that person, 70% of the people shave it back. That's when I use those acid pads. They'll use those as we instruct them to for a few weeks, trim it back a little bit more. The wart slowly starts going away. Does that work every time? That would be wonderful, but that would be too easy. When it doesn't work that well, and the wart may have been very long standing and may be very large, that is the person we cut it out. You either take them to the hospital, make them sleepy, or you just give them a shot of Novocaine, cut it out, and you let the skin grow over it. Most people do very, very well with that. But once again, typically, if that painful callus is right under your knuckle, that's from an abnormal bone, typically not from a wart. Where do warts come from? A virus.
Dr. Faircloth.
See them more on people who go to the gym. Yes.
I'm sorry, go ahead.
Uh-huh.
Okay, let me get this
No,
right.
you were asking me a question.
Yes, ma'am. Let me get this before Dr. Brown cut this session off. this is a plug for you. I was told that we all have some type of leg imperfection, and the only way of balancing the body is to get fitted with orthotics. Is that a true or false statement?
I would say that's a false statement. That's someone trying to make money. I'm gonna tell you, I really pride myself, and I hope that I never get to the point where I try to do what's best for my patient, what's not gonna be best for my pocket. But like I told you, I try to use real life examples. Do everybody need eyeglasses? No. Orthotics are like eyeglasses for your feet. We all have some kind of body imperfection. That doesn't mean it has to be addressed if it's not bothering you. Everybody doesn't need orthotics. Orthotics cost $400 and $500. Everybody can't afford that. But my easy example is everyone doesn't need to wear glasses. So no, everyone doesn't need to have orthotics. I would say, and once again, I don't like to know who people go to because I'm not in the business of bad mouthing people, but I would say that is someone who's trying to make some money. I have a lot of patients that go, well, I went to so-and-so and why I need to get both of my orthotics replaced. Both? Why? Well, he told me I needed 2 pair, one for my sneakers and one for my dress shoes. You know what? I have a congenital foot deformity. And yes, I wore orthotics when I was younger. And I'm gonna tell you, I don't even wear them anymore because I do very well. As I've gotten older, I need more shock absorption and I do much better with the generic ones that we issue. But when I wore orthotics for 30 some years, and I'm telling you, I wore the exact same pair. And when I make orthotics for patients, I try to make them so that they accommodate both of your shoes, your dress shoes as well as your sneakers. I'm a runner. I used to be a competitive bodybuilder, work out a lot. And I'm gonna tell you, the ones that I worked out in and ran in are the exact same orthotics I wore in my dress shoes, exact ones. And I would keep my orthotics for 8-10 years at the time. So anyone that tells you you need orthotics, a new pair every year, they're trying to make some money, okay? Anyone that tells you you need more than 1 pair, they're trying to make some money. Do I have people I've issued 2 pairs to? Yes, because that was their choice, especially if it's a lady who wears very narrow high heel pumps, even though the ones I make, you can typically wear in high heels as well as your sneakers, and they still do the same job. It's very, very unfortunate that everything this day and age, I don't care what profession it is, has become a business. Especially with medicine, a lot of us have gotten away from, let me treat this patient and what's best for my patient. Personally, I truly try to treat my patient appropriately. I want him to be well, but if I know I can get you well by you spending $10 instead of you giving me $400, that $400 is making my pocket awful fat. But I don't have the heart to do that when I know there's a less expensive way that's going to work just as well. But once again, every business, I can't think of a single business right now that money is first and foremost. Medicine used to be what is best for the patient, but you can see for yourselves when you go to a doctor, or even if you go to a hospital, they're looking at they're looking at that dollar first. They're looking at that dollar margin, which is, I think, especially in healthcare, is very unfortunate. We talked about bone spurs, we talked about calluses, we talked about arthritis in the foot, we talked about fractures, chronic ankle sprains. Geez, my ankle won't stop hurting. I twisted it. Well, sometimes that person, once again, cortisone shot, physical therapy, they may be absolutely fine. Well, they don't respond. That's when I get an MRI or an X-ray. Is there any significant arthritis there? Or is there any torn ligaments that need to be, not all torn ligaments need to be addressed, but there may be a torn ligament, or there may be a loose piece of cartilage in the ankle joint that needs to be removed. This day and age, we can typically suck that loose cartilage out via arthroscopic surgery, which is just 3 little holes using a camera. Some people may have an advanced amount of arthritis in their joint that they've just been dealing with for a long time and they can't deal with it anymore. That is the person that may need a total ankle joint. Just like people get knee and hip replacements, we do sometimes replace the knee. We do sometimes replace the ankle. We do sometimes replace the joint in the big toe. So sometimes if you have enough of an arthritic process that's been going on long enough, it may be need to address with an implant. But typically a chronic ankle sprain, physical therapy, and some kind of steroid, whether it's by mouth or injection, typically 90% that person is well on their way.
Thank you, Dr.
Is there anything else?
Dr. Faircloth,
there is one
can
more
I ask
thing.
you one question and then we'll close out?
Okay, but there is one thing. I'm gonna let you ask your
Oh,
question.
go
There's
ahead.
just one more
No,
quick
you
thing I
go.
want to touch on. Go ahead.
Go.
You want me to go first? One thing that, once again, a lot of people miss. Well, I'm a little bit of everywhere. I have an office in Midlothian, an office in Churchill, but I also work out of I work out of a wound clinic for HCA. I work out of a wound clinic for Bon Secours. You cannot imagine the number of people that come to me with wounds on their legs or wounds on their feet that have been long-standing for, we're talking months. Most of them, it was so simple to cure them, but they just weren't getting the adequate treatment from their primary care, or they just weren't going to anybody for it. You just don't want to ignore a wound, especially a wound that is more than 2 weeks old. You don't even want to go a week if it's red, swollen, and that redness is increasing. If that redness is growing, you are getting septic. Septic is a life-threatening issue. That's what folks used to call blood poisoning. We don't want that. Please don't ignore wounds. They can typically be taken care of. Some of them may be arterial or venous related, and those circulatory systems need to be addressed, and you don't realize it. I can't tell you how many people I see with gangrenous wounds, gangrenous toes. Yes, by then I do have to cut something out, but my goal at that point is to minimize the amount of tissue that they have to lose. I just want to make sure you know, just because you're not diabetic doesn't mean it's a wise decision to ignore a wound. And if you're going to see someone, I don't care if it's me, I don't care if it's my partner, I don't care if it's your primary care doctor. If you're getting treatment for a wound and it is not progressing, now granted, some wounds is going to take a few weeks for it to progress. But if that person hasn't done x-rays, they haven't done cultures to make sure there's no brewing infection, you need to say, let me get to a wound clinic or let me get to someone else that can tell me a little bit more about this wound. I just want you to realize the importance of not ignoring a wound. A lot of people will, oh, well, I'm not diabetic. You know what? Regular people have the same problems diabetics have. Diabetics, it may be exacerbated for 2 reasons. Their circulation may be a little bit slower, but more than anything, they don't feel that wound. That wound doesn't hurt. That doesn't mean it's not dangerous. Any long-standing wound can be dangerous. It can also indicate cancer. A long-standing wound can translate into, can eventually become cancerous if it's there long enough. So just don't ignore a wound. All righty. Somebody was about to ask me a question.
Yes, Dr. Faircloth, last question, and then we thank you so very much. You are the only
Thank you for having me.
Yes, you're the only Black podiatrist that I know, period, and have ever known. Why did you go that way?
Well, when I came to Richmond, I will tell you that I was the only Black female and the only Black surgically board certified for well over 10, 12 years. I think there's another female here now. There are 1 or 2 Black surgically certified here now, but I was the only one for a very long time. I went that route because I had, like I said, I have some congenital foot deformities, and I had a lot of procedures throughout the years. And I guess I just got so familiar with it that it really interested me. And here I am.
Thank you for
That's why I went
answering.
that route. There
Dr.
is
Faircloth,
one thing, yes,
I am happy that
uh-huh.
your feet led you to become a member of Fifth Baptist Church. So I compliment you on your feet.
Well, thank you. Thank you.
Amen.
I
We
am
thank
glad
you
it
so
did
very much.
too.
Thank you so
Can I
very much.
have just one closing statement? Can I have just one closing
You may.
statement?
Yes.
Reverend Brown knows I can talk just as much as he does. He knows that, because sometimes we'll get on the phone, and I have a sister that sometimes stays at my house, and she'll ask me, "You still talking to your pastor all this long? What y'all talking about?" But I just have one thing left to say before we close. John 1st chapter, 2nd verse. Dear friend, I pray that you may enjoy good health, and that may go well with you, even when your soul is getting well. So thank you all. Like I said, I'm Dr. Faircloth. I have an office in Midlothian. I have an office in Churchill. My name is too easy to remember, Faircloth, but Fifth Baptist can tell you where I am. If you need to contact me for anything, I'll be more than happy to further answer any questions. If you want to see me as a patient, I'm more than happy for that as well. But once again, thank you so much for having me. I do like talking to groups. As Reverend Brown stated in the beginning, I really, really do like talking to youth groups. I think I even talked to a group of men once, didn't I, Reverend Brown, about prostate cancer? And I think that was about 15 years ago, and that was received very, very well. So it's not just about feet, and I would be more than happy. About 15 years ago, yes, sir, it was. That's when you were about 25.
The fantastic seniors are waiting for you to talk with us. Amen. Thank you so much. Thank all of the
you all
listeners.
just let me know when.
And may we all treat our feet better and see somebody who have.
And thank you all for having me.
And now may the grace of God and sweet communion of our Holy Spirit rest with all of us. And may we all have a restful night. In your name we pray. Amen. God bless.
Amen. Thank you. Good night, everyone.
Okay, thank you very much.
Dr. Faircloth, thank you so much. A lot of great information.
Well, thank you for listening. I hope I was of some help.
Thank you, Dr. Faircloth.